been scarred and I've been bruised. I have learned just what to do. I need to leave my past behind me. I need to look to the future. No matter what will come, no matter what I've done, I know just what to do. And that's all because of you.
Hello, you okay family? Welcome back to my YouTube channel. My name is Yana Mavumengwana and you are back to You Okay. It's another Tuesday and I'm bringing you something that you have been begging for, recommending, inboxing, doing so much to make sure I bring this topic to you. I have thought long and hard about it and I have brought what I think is the best person to deliver this topic to you. But before we get to that, let's get housekeeping out of the way. Most importantly, production break. We are going to go on a recess break during the December period. So I want to give you a heads up so that it's not by surprise. We've been so consistent. Well done to us. Every Tuesday at the same time since we premiered, and I want you to know ahead of time when that schedule is going to be interrupted. So it will be on your screens for the last time this year on the 1st of December. That will be a Tuesday, and then we'll only be back when your routines kind of stabilize again in the new year. Say second week or so. I'll keep you posted about our date of return, but we are going on a production break during December, and that's it for housekeeping. Welcome back to the people that have been with us since that premiere and the people that have joined alongside the way, and a warm welcome to the people that are new. As you can see on your screen today, we've got the biggest terrorist when it comes to mental health issues. Seems to be affecting more people as society is modernizing and as things are evolving, and obviously during this unique time as well, we are seeing a higher prevalence than what we normally see, and I want you to understand something about it as well, that it's more than just a psychosocial problem. There's a bigger I suppose mechanism behind a depressive episode, and I have brought a person that is going to help us understand that a bit better, and that's a depressive episode understood from a biological perspective, that it's more than just a feeling thing. It might be a mood disorder, but moods are regulated by biological mechanisms, and Dr. Lerato Melado is here to share that with us. Lerato is a psychiatry registrar, so we're sitting with a brown skin girl, a specialist in training. Yes, this is Lerato. She's specializing in psychiatry, and she is going to introduce herself. You okay, family? Please welcome to the couch, Dr. Lerato Melado. Drum roll! Lady, welcome. And thank you for coming, guys.
Thank you for having me.
I'm your plug. Take me seriously. I got you. Welcome to the couch. I have introduced you. Lerato and I are former colleagues. When I worked for a psychiatric unit, she was one of the registrars there. And yeah, Lerato, introduce yourself. Who are you? You've had like a whole baby since the last time.
Yes. So my name is Dr. Lerato Meladu. Like she mentioned, the psychiatry registrar based in Port Elizabeth at Doringenza Hospital. And I'm very happy to be here, very excited to be here. And as she mentioned, I just had a baby, so mental health is very important. I know it very well.
You understood it a little differently. You understood it a little differently.
I did.
Larry, we're talking depression today. We're talking depression. And I want you to start at concept definition, because as much as we throw the term so loosely, if you sit a person down and say, actually, what are you talking about? You see, but that's not even what it is. So even the people that are using this term so regularly have no conceptual understanding of the term. So for at the most basic level, what is a depressive episode? When we're saying a person is depressed, what do we actually mean?
So basically, depression is a mood disorder, and essentially what it means is that, you know, everyone has moods and emotions, and it's basically a spectrum. And depression is seen to be on the severe side of sadness and feelings of depressed. So yes, there are instances where every now and again something will make you sad or you'll feel like you're depressed. But when we talk about depression, we're talking about something that is sustained and something that's more pervasive over a period of time. So we're not talking about a day here and there. We're talking about something that happens for most days, most of the day, for a period of at least 2 weeks. And when we talk about depression, what makes it so significant is the impact that it has on your level of functioning, which is where then a psychiatrist, or actually tending to a psychologist or any doctor, actually becomes then necessary, because that's when you're functioning either at home, at work, at school. When that's impacted, that's when we then do become concerned. And as she mentioned, depression is a disorder that's become very prevalent lately in our society, and understanding it helps us manage our patients better, because very often you see that depression doesn't go alone. Either it goes with another psychiatric condition like anxiety, or depression will go with other medical disorders. So we found that certain medical conditions make depression more prevalent, and depression can make certain disorders more prevalent as well. So it's important to understand depression and to
Conceptualize
identify it so that we can treat it, because a person with depression who's not adequately treated, it makes it difficult to manage the other disorders that the patient has. So that's why depression is important to know here.
And in our thinking about depression, what I have found is that our biggest limitation is limiting or thinly defining the description of depression as understanding it as just my feelings. And the biggest part of it is that it's more than just that. And to reverse it, you need to understand the mechanisms, like the diagnosis or the genesis of a depressive episode needs to inform the kind of intervention you're then going to get. So people then refuse to take medication because they haven't understood that the only way to reverse that malfunctioning mechanism is medication, because it's in fact biological. To the layperson, from a biological perspective, what is actually going on with your mind when you are depressed? What is it supposed to be doing that it is not doing well or not doing correctly? What has gone wrong? Because clearly there's normal development and something has gone wrong. And what is that thing that is going wrong? Is there something that should be happening, that your body is struggling to take care of it on its own? Or what is actually going on to your mind that isn't going on in the mind of a non-depressed person?
Yeah. So in understanding depression, it's very important to understand that there's not one single thing that causes depression. It's a combination of different factors that have come together to make you depressed in that instance. So when we talk about that, it's important to acknowledge the fact that depression, your susceptibility to depression actually starts with your genetics. So if you've got a strong family history of depression, most importantly, a first-degree relative. When we talk of first-degree relative, we're talking about either your mother, your father, your brother, your sister. When they have depression, you're more at risk of developing depression, because there's that genetic susceptibility in your family.
So you're vulnerable.
You're vulnerable. Also, what also increases your vulnerability is early childhood traumas. So if you've experienced something in the early years of your life, be it physical, emotional, sexual abuse, even parental neglect, even a situation where you were removed from your parent, maybe your parent was sick or your parent had other things going on, that can also increase your susceptibility,
So
or your
vulnerability,
vulnerability, yes, to depression. Then also, with that said, anything that happens in your life, such as, so we call them environmental factors, so any stressful events as well. And when we say stressful events, we're not all going to respond the same way to stressful events. You know, our ability to cope in situations differs from person to person. So with that said, your temperament also judges how you're going to respond to a stressful event. And when we speak about temperament, we speak about basically your response to situations. So for instance,
like your sensitivity
exactly.
to things,
So if you're someone who tends to avoid conflict, if you're someone who tends to internalize issues or things that are happening around you, you're also then more vulnerable to depression. With that said as well, looking at your social support. So if you're in a situation where you have very limited support, maybe family or friends not around, you also then become more vulnerable to depression. But this is now all the factors that may increase your vulnerability. Now, when we talk about what happens in the brain of a depressed person, there are a number of factors that happen. First of all, there are changes in the functioning of certain areas in your brain. So we know that the brain's got different parts that do different things. But the places that we're the most concerned about are areas like right here in the front of your brain, like the prefrontal cortex, a hippocampus, which is basically the part that is involved in your memory. And then we also look at areas such as your limbic system, which involves your emotions. And when there are issues in those areas, this also helps further explain the features that we get when we're depressed. So things that affect your prefrontal cortex, that explains why you struggle with concentration. That explains why you struggle to finish tasks. That explains why you feel like your mind is busy and you can't focus on one thing. When we talk about issues in your hippocampus, that explains why you have memory problems, why you can't retain new information. When we speak about your limbic system, that's your lack of motivation. So things like not wanting to get out of bed, not wanting to shower, not wanting to spend time with your friends and family, that has to do with a malfunctioning in your limbic system. Also, that lack of desire, that not finding pleasure in things that used to bring you joy. That's all related. We also have areas that also control your sleep cycle. So things that affect your ability, whether you're sleeping too much or sleeping too little, also has to do with depression. And also, moreover, besides the functioning of those areas, we have little chemicals in the brain that all move in. Oh, sorry.
Sorry to you.
Sorry, sorry. Little areas in your brain where they go and they whiz through everywhere. And these chemicals, when there are times that these chemicals are either deficient or the receptors that take up those chemicals aren't working properly, that can also lead to a depression as well.
That's a beautiful concept definition for me, primarily because of the level of shame it removes. Because if someone is going to talk brain mechanisms, it removes a certain level of responsibility from thinking that you have done something, or you're doing too little of something, or the people that are coping better than you made a wiser decision that you did. Now, I don't care how wise you are and how brilliant you are. These are some of the things you can't personally engineer. I hope it excuses you from the responsibility of considering yourself as a weaker person, or looking at people with a better brain or less vulnerability than you do as if they are better people than you. A lot of it is kind of out of your hands. And that speaks to then the mechanisms you're going to use to try and reverse or fight that situation. And the next question I'm going to ask Dr. Lerato is that normally when you encounter a medical practitioner to address this problem, the first recommendation they will often make to you is pharmacology. And most people resist this. And now that she's explained to me just how biological some of the injuries and deficits can be, it makes sense for me then why pharmacological treatment would be the chosen mechanism to try and balance that. Larry, what is medication actually supposed to do? Why do we need to take it?
Yeah. So with your antidepressants are important because they actually target those small chemicals that we spoke about earlier. They help your brain, they increase your brain's ability to accept those chemicals, which then helps the functioning of the brain, especially in those areas that we spoke about. So that's where medication is important. What medication also does is that it prevents further damage or injury to areas of the brain that were previously vulnerable, and it also prevents a relapse. So that's where medication becomes important, is because you have a depressive episode, but certain people are more at risk of having another depressive episode than others. So for instance, if I had a family history of depression, if I had been depressed before when I was pregnant, if I had a lot of stressful situations right now with poor social support, I then become more at risk of having a relapse later on again. So when we talk about taking medication, we want to prevent a relapse, because not only does that in the long run affect your ability to function, but a relapse also then makes it further damages your brain, and that's where we also want to try and prevent what can happen with depression.
And most people know this, and they actually are so diligent in attempting to get on the medication. And the first thing that they normally encounter is how drastic the changes that happen to their bodies and their feelings and their minds, which is often disappointing, because then they took medication because I wanted to reverse the bad stuff. Now I'm on the medication and more bad stuff is happening, in things like weight gain, and then they impact your self-image. That makes you more sad, and then it just looks like the medication itself isn't worth it. Let's talk side effects. Side effects are one of the biggest reasons behind non-adherence or poor adherence, despite the fact that people know I still need the help. What do people do in the case of side effects? What kind of side effects that are typical when people get on an antidepressant? How long are they likely to last? What do you do when you notice them? Do you wait it out? Do you intermittently take your meds? Do you take your meds and then other meds to reverse the side effects? Or what do you do?
So it depends, because we've got different classes of antidepressants. So not all of them will give you the same side effects, because they work on different chemicals in your brain. With that said, there are certain antidepressants that we tend to use what you call first-line treatments, such as your selective serotonin reuptake inhibitors. And we choose these because these have a more beneficial side effect profile, and they tend to be more tolerated by other people. So like medication, though, even though SSRIs tend to be better in terms of tolerance, they do also have their own side effects. So we're talking about things like a dry mouth, we're talking about diarrhea, we're talking about nausea. Patients can also have sexual dysfunction, particularly in males, which we don't speak about. Your insomnia can get worse initially. You can feel even more anxious when you start antidepressants. And this is important that you ask your treating doctor about these things, because the more aware you are of the side effects that you could experience, the more likely you are to continue medication. And not everyone is going to experience side effects to the same drugs all the time. So, for instance, when you take an SSRI that I mentioned just now, like citalopram, in the first 2 weeks, we educate our patients that be aware that your insomnia could get worse and your anxiety is going to get worse. And that has to do with the way the drug works initially. But this is also transient, it won't last. But what we can do is we do offer to cover with a benzodiazepine, which is a medication that we can give to help with the sleep in the first 2 weeks. Obviously, we're not going to give that long term, and then you'll start seeing that the side effects will get better. Other things to consider is that certain drugs have better, won't cause sexual dysfunction as much as other drugs. So you can also consider switching the medication. You can consider decreasing the dose of the medication, or you can augment it with another drug. Another thing that also helps is considering other treatment options, so such as psychotherapy is also beneficial. So we found that research shows that treating with antidepressants initially helps with the initial improvement of the symptomatology, but psychotherapy actually gives you sustained and long-term improvement of your depressive symptoms. So yes, medication is an option, but it's not necessary for everyone who's depressed.
And not the only option.
And it's not the only option. There are other options such as electroconvulsive therapy, but that was something you'd have to discuss with your treating psychiatrist. It's not offered to everyone. But there are options out there. Antidepressants aren't the only option, but they're
highly effective.
They're very effective. They work really well, especially in the initial phase. Most people tend to get better within the first 2 weeks of treatment, but you need to give it at least 6 to 8 weeks for you to feel that you are getting better on antidepressants.
Most important question, is it longitudinal? Must I take this medication for the rest of my life is another popular question, that if I take this treatment, will I need to take it for the rest of my life, or is there a time where you're going to say I've improved enough to try being off the medication and see how I cope? Or is it initially just meant for a brief period until you are over the difficult thing, if you are going through a difficult thing? Or what happens? What decides how longitudinal you're going to be on that medication? Because some people are on it forever and some people are briefly on their medication. So what decides how long you are going to be on your medication?
So that's actually a good question. So when we talk about the duration of treatment, that also depends on your duration of depressive symptoms. So what we aim to do is to treat you for the duration that you were depressed for. So let's say if you were depressed for 6 months before you came to us, we'll treat you for 6 months plus, let's say, another 6 months or another year. It also depends on how many times you've been depressed before. Okay. So if you've been depressed 2 or 3 times before, we're more likely to put you on treatment for 2 to 3 years. It also depends on what type of depression you have. So you have that people have depression that is more seasonal, such as patients more in like the UK. You also tend to have people who have depression that is related to their menstrual cycles. So those patients can even consider taking antidepressants just for their menstrual periods, and then when they're off their period, then they can be off the antidepressants. So it really depends on your type of depression, depends on your profile as a patient, and it also depends on your risk of a relapse, and that's the most important thing.
Depression is often accompanied by a lot of psychophysiological symptoms, things like sleep, things like appetite, things like energy. Talk a bit about those, because I think we talk depression because it's primarily understood as a mood disorder. People just expect the mood part of it, and they have less sympathy or empathy for things like cognitive problems, like when you start struggling with your concentration, struggling with your memory, and other psychophysiological problems like energy, sex drive, and appetite. Comprehensively include the non-mood things in making me understand depression as well.
Yes, so as mentioned, we do focus on the depressed mood, and that's the one that tends to be more in your face, that people acknowledge or recognize from the word go. But we do have almost the more insidious, more sinister features, so as like cognitive features, so the decrease in your concentration, your inability to complete tasks. We also have your what we call vegetative symptoms, so things like changes to your sleep pattern. So you can have what's called insomnia, which everyone knows is your inability to have restorative sleep, but you also have something called hypersomnia, where you're actually sleeping a lot, but you actually still aren't feeling rested. Then we have changes to your appetite. So you could either have a decrease in your appetite, or you can have an increase in your appetite. We also have changes in your weight, so you can have increases or decreases in your weight, and this is unintentional changes to your weight. Then we can also have changes to your libido and your sex drive, where you're no longer finding pleasure or interest in sexual activity as you did before. And then we have then other things such as the more that has to do with the psychology behind it, is things like these intense feelings of guilt, this decreased desire. You have these thoughts about death, so you might not necessarily even have suicidal ideation or want to kill yourself, but it's that the preoccupation with death is also a feature that we need to recognize, because it's not as obvious as suicidality. And so those are the things that we need to be aware of. And even feelings of worthlessness, where you have these significant negative thoughts and negative assumptions about yourself and about the world. It's that where you literally find yourself in a loop of negative thoughts going on and on and on. And those are the ones that aren't as obvious to the eye, such as a depressed mood. And those are the ones that we also need to be aware of.
In some cases of very, very high severity, hospitalization is normally an option as well, and normally an appreciated option
Yes.
by most people, and one that carries a lot of stigma when you come out of hospital. Please help me destigmatize a little bit why sometimes hospitalization is a necessity in the treatment of a depressive episode, and why people should be active and take agency in seeking it. Sometimes, what is the benefit of hospitalization above and beyond just pharmacology?
Yeah.
Who are we likely to admit to hospital?
Yeah, so hospitalization, it's important for your more severe depressive episodes. And it's important because we do it for the safety of the patient, and it's also for the safety of those around you. Sometimes you find yourself in a situation where the very circumstances that you find yourself in perpetuate this depressive episode. And hospitalization gives you that ability to be taken out of that situation so that we can focus on you as an individual. So not only will you be given medication, you'll also, have exposure to a psychologist, an occupational therapist, a social worker, and these are people that work holistically, and what we call a multidisciplinary team that work for your good, to not only give you the medication to help you in the acute phase, but also to equip you with the resources so that you don't have a relapse, and so that you don't need hospitalization again. But hospitalization is not a bad thing. No one is punishing you. No one is forcing you to stay in the hospital because we want to be mean to you. I mean, we all know that it's not nice being in a hospital, whether it's an appendix or a toe or depression. You don't want to be in a hospital. But the same way that you go to a hospital for an appendix is the same way that you go to a hospital for a depression, is to treat something, and so that you leave the hospital better than you were when you came in.
And I think most importantly, the access to the practitioners isn't typically a setup you would get outside. To have all of them every day at that high frequency, at that high vigor, continuously just dealing with you day in, day out. So it's like declaring a biological warfare against a depressive episode, and sometimes it needs that level of vigor. We've run out of time, but I think you have found great value in having Lerato here. I know that I have, and you can drop more of your questions. I'm going to ask you to come back. I'm going to ask you to come back because mental health symptoms overlap so much that it's normally careless to discuss just one in isolation, because a person will pick up the symptomatology and think, I have that, until they hear more other things that actually better account for their symptom profile than just depression. And there's a high comorbidity tendency when it comes to psychiatric issues. So one tends to have an evil twin that is the other, like depression and anxiety. So it helps when you know of more. Please don't try and diagnose yourself as well. A diagnostic criteria is something to be left to the people trained to diagnose. This is to help you have words for your experiences and definitions for the things that you go through, but most importantly to normalize and to humanize that there's nothing wrong with you, and to offer hope that these things are so treatable. For every problem that I identified, there was an accompanying solution. So you are not stuck, you are not in this bottomless pit. There are people that know how to get you out, have trained techniques that are proven, as effective in getting you out. So this is to normalize you. This is to offer you hope that you may not know of the solution, but specialists and mental health practitioners do know of the solution. And all you need to do is to get in touch with them. Last words, Larry, before you step off the UK couch. What do you want to say? Say a person is depressed, they are watching, what would be the last thing you want to say to them?
Yes. So my last thing is that, you know, depression is a very isolating, very painful disorder. But I know it's a cliche to say that you're not alone, but in all honesty, you're not alone. And the sooner you seek help or you tell anyone about what's going on, the better it will be for you in the long run. And depression is tricky because it can hit you wherever you are, in any sphere or point in your life. And you did nothing wrong, and there's nothing wrong with you. You cannot be the judge of what happens in your genetics and your exposures in life. But you know, there is help, and there are doctors, there are psychologists, social workers, occupational therapists, a whole array of people that are always willing to help you. And just call someone, let someone know, drop someone an inbox. You know, we're all here for you, and it's only just to make you better.
Thank you so much, you guys. I know it's harder to be mad at the invisible and things like it's your genes, or it was your parents, or it was this, and things that are concrete and you can point at. So that normally just leaves you to take the blame, but don't fall for that bias of thinking, well, I don't see genetics, I don't see brain vulnerability, so clearly the problem must be me. I hope this has helped in letting you know that the problem isn't you, and vulnerability isn't something you personally engineer, but you are not out of options. And people are here for you, and staff is here for you. We will bring her back and talk more things, because depression sometimes can be a feature in another psychiatric condition altogether. So you'll see there'll be changes in mood as well if you talk, let's say, post-traumatic stress disorder. So you don't want to talk these things in isolation. And guys, and right? I know you. I know Thank you so much at home for your consistency. Thank you so much for your ongoing collaboration in terms of what will make this channel a good experience for you. This was one of your recommendations, and I was very proud to deliver it to you. I will be up after Lerado to discuss with you guys the non-biological things. As she said, psychotherapy is one of the evidence-based ways to treat a depressive episode alongside medication. You've got a bomb-ass winning combination when you actually have both. So I'm going to talk that and the more social elements, because I think the most ignored people are the people that live around depressed people. So I do want to touch on that as a psychotherapist as well. How do you better support these people? How do you date them? How do you parent them? And how do you move yourself out of your own depressive episode? And how I hope you are empowered, and it could, even if you haven't been depressed yet, I think even a person that has never had depression, after listening to this, is a different patient when they eventually have a depressive episode, by just having this information. So thank you for your patience, for listening, even though you don't relate personally to your depressive episode. And we will see you when we come discuss the psychotherapy, I suppose, around depression. And we'll be back again and again with more things that bring you better outcomes for your mental health. Thank you, Larry.
Thanks for having me.
Thank you. Thank you. Bye.